Patients may ask you if hypertension is different from high blood pressure, but those are two different terms from the same condition. The term hypertension used more in the medical circles because it's more precise linguistically from the Greek word hyper, which means above, and tension, which means pressure. The high blood pressure is generally used by the public, and in public health ads and service campaigns, the only way to know for sure if one is hypertension is when you measure it. So, in this lecture, we're going to discuss what's in the textbook as well as the newly published 2025 American Heart Association Hypertension Guidelines. And we're going to talk about what defines hypertension, causative factors leading to hypertension, the types of hypertension, and various treatment and management strategies for patients with hypertension. And there's going to be some minimal discussion on hypertension and pregnancy, as you'll see in the guidelines, but this was already covered in a previous course with much greater detail, so we're not going to go too much into that. The one thing I will tell you is you will see patients, especially if you work in emergency situations, where people will come in after they deliver with some hypertension that is remaining, and you will see it before the baby is born with preeclampsia. So be aware that some patients may already start having some hypertension before sometimes they even know that they're pregnant. So it is something that you need to watch out for. So hopefully you will have those notes on pregnancy in your previous coursework. So regardless of the terms that we talked about, having hypertension can over time lead to some severe health complications. And even though patients may never experience those symptoms, and that's why it's called the silent killer, out of all the risk factors that cause cardiovascular disease, hypertension is one of the number one ways you can prevent about 80% of those cardiovascular diseases. And those include diseases that range from peripheral vascular disease all the way to heart attacks to cognitive disorders like Alzheimer's. And so, what causes hypertension? Well, blood pressure is the force of blood against the walls of the arteries, and as the heart pumps the blood through the body, each time the heart contracts, that systolic pressure is transferred from the contraction of the heart muscle to the blood, which then exerts that pressure as it flows through the blood vessels. And hypertension can result from this consistent increase in cardiac output, peripheral resistance from the blood vessels in the body, and in those smaller blood vessels as farther south you go to your toes. So if it's left untreated, it can cause damage to blood vessels and organs, as well as put people at risk for those cardiac diseases or cardiovascular diseases, just as listed. So when we talk about those organs, we're talking about in the hypertensive terms. In the literature, you're going to talk or hear about target organs, and they're going to be looking at those things. That would be things like your kidneys or um, metabolic syndromes, your lungs, your heart, that kind of thing. So you'll be looking at blood vessels, veins, arteries, that type of thing. So when they talk about target organs, that's what they're looking at. Some terms that we talked about throughout this whole series on the cardiovascular system have to do with peripheral resistance, cardiac output, stroke volume, and the like. So remember that your blood pressure is your cardiac output times your peripheral resistance, and your cardiac output equals the heart rate times your stroke volume. And remember that that stroke volume is the amount of blood every time blood is ejected from the left ventricle with each systolic contraction. And that increases in cardiac output are directly related to the expansion in that vascular volume. So if you have more blood volume, that whole stroke volume is going to increase with that. So it's all relative to what that expansion in your blood volume is. So in 2017, the American Heart Association guideline lowered the diagnosis for hypertension to greater than 130 over 80 millimeters per mercury. I'm sorry, I'm stuttering. This change reclassified over about 30 million Americans as having hypertension, which is about 14% of the adult population, making them eligible for treatment if they become at high risk for cardiovascular disease. This year, the new guidelines been published in this month in August, about mid-August, in the adult blood pressure categories remain virtually unchanged, except for the fact that they're starting to look a little bit more in depth to middle-aged people around starting at the age of 30. And we'll talk about that a little bit more, but they're going to be looking at more of the prevent guidelines or equations for assessing cardiovascular risk rather than some of the previous assessment tools that they use that were basically singling out specific cardiovascular diseases. And we'll talk about the prevent equations in a little bit more detail. But you can look at this slide here, which talks about the different categories. And the one on the right, the 2025, it's the same professional organizations and professional teams that have gotten together to research the guidelines together and put together this whole section of guidelines and what medications are used, how they handle management of hypertension is so important. And last time that we were together in class, we talked about what our future is going to look like. And stroke is going to outweigh everything else as far as some of the future cardiovascular problems that we have. And that's going to be by the year 2050, we're going to see a steep incline in cardiovascular and stroke and cognitive related disorders. So it's something that we need to start looking at. And this group of professionals and researchers got together, and of course, nursing is included in that. And one of our founders of evidence-based practice is in on this whole group of people that wrote these guidelines. So it's important that nursing was at the table, and they certainly were. So their uh, their research derived data from about 3 million patients and the variables that surrounded them. And one thing that they added to this group was that they looked more to associate with that Framingham score for heart failure. And when you look at the prevent, it stands for predicting risk of cardiovascular disease events. The American Heart Association and the American College of Cardiologists believes that this will better help providers lower hypertension rates, which will help modify damage long term if they start earlier, uh, uh, around the age of 30. And that's when the people think that everything is okay. And that's when most women feel like the estrogen in their bodies or protect them from hypertension. Then that may be so, but there are some evidence to say otherwise. And we'll talk about that too. It's pretty interesting. So essential hypertension is, or primary hypertension is about 90 to 95% of all people diagnosed with hypertension. And there's lots of people walking around today that are undiagnosed hypertensive patients. And so that's why we're having this concentration on hypertension in this section of our studies. So this is high blood pressure that isn't caused by any other medical condition. You just have high blood pressure. No it's not a medication or a substance that's causing it. It could be basically the way you were born, but not necessarily. So as time goes by and we are learn more about genetics and all of that, we're finding that sometimes there's just no known cause for it. As people age, the only factor is wear and tear of the pressure of the blood on the intima of the wall of the blood vessels. And sometimes there's just loss of elasticity and collagen, which accelerates the formation of plaque from cholesterol, which causes a systolic blood pressure to rise over time. And this is called isolated systolic hypertension. This is seen mostly in the elderly, and it's sometimes difficult because the diastolic pressure remains normal and there are no drugs that specifically treat systolic blood pressure alone. So when you look at this slide here, you'll see that there's stiffening of arteries over age is part of the damage of just the wear and tear of blood volume running through the vessels, and what we eat and the pollutants that were around, the toxins that were around, all these things are just part of um, what we experience on a day-to-day basis. So this is you'll need to remember what essential hypertension is or primary hypertension. Those terms are the same. And I wish that there would just be one term that was the same for everything, but they always have multiple terms for the same thing. But essential hypertension and primary hypertension are the same, and they are 90 to 90% of all people that are diagnosed with hypertension. Secondary hypertension, on the other hand, arises from some other, often treatable condition. It can also be caused by some kind of medication or substance as well. So, the leading cause of secondary hypertension is hyperaldosteronism. And this is the overproduction of aldosterone by the adrenal glands. And as you know, the adrenal glands are located above the kidneys. Aldosterone helps potassium and sodium regulation in the body, and an excess causes the body to retain sodium and lose potassium, which in turn leads to high blood pressure and fluid retention. And about 1 in every 15 people with high blood pressure may have this hyperaldosteronism, and it's maybe even more common among people with poorly controlled or resistant hypertension. So when we look at primary versus the secondary aldosteronism, of course, you get segments and offshoots of all of these things. One of the common causes is Conn syndrome, and this is a benign or a non-cancerous growth in one adrenal gland. And the primary aldosteronism is not only causing this high blood pressure with low potassium, but it can also bring on excessive thirst, being extremely fatigued and frequent urination, along with headache, muscle cramps, and weakness or tingling in your extremities. So, in your hands. And so, people can have idiopathic hyperaldosteronism or an overactivity in both adrenal glands, and there's no known cause for it. The secondary hyperaldosteronism stems from issues related to diet, genetics, or a problem with the liver or the heart. So this is important to know too. The hallmark sign of this hyperaldosteronism, and this is not all inclusive, and it's not always indicative of every single person, but it is the hallmark sign, which means that you're supposed to be pricking up your ears to be looking at your electrolytes, is low levels of serum potassium, which can cause the weakness and the fatigue, the heart rhythm abnormalities, and muscle cramping. So if you're looking at a patient or finding that they're having this high blood pressure and low potassium, they may need a blood test for aldosterone, and this is when you look at your kidney proteins and your renins. Okay, you're looking at the blood renin. An MRI or CT scan of the abdomen can reveal this abnormal growth on the adrenal gland, and blood samples taken from both the right and left adrenal veins can identify which of the two adrenal glands is making too much of this aldosterone. So it's a little bit more invasive than what you would be taking from your veins in your arms as a regular blood test. So you would have to actually look further into the adrenal glands. Minimally invasive surgery to remove that affected gland can often just completely correct the situation. So if you have somebody that is just having some very high problems with resistant blood pressure, they may just have to remove that affected gland. The next part of the secondary hypertension is a kidney or renal artery stenosis. Some causes of the renal artery stenosis require bypass surgery, but most can be treated successfully with angioplasty these days. And so this procedure dilates the constricted artery with an inflatable balloon that's attached to a catheter. And this is the perfect reason to understand why kidneys play such an important role in blood pressure control and management. Well, the blood flows through the kidneys, and your kidneys are basically a sponge-like type organ, and it looks like broccoli trees when you get inside the kidney. It's very interesting how they form, but they're the filtration system of the body. And so when you look at the kidney, they branch into the successively smaller vessels, which finally end up in these small clusters of capillaries known as glomeruli. And each cluster or glomerulus is part of a nephron. And this is a tube-like structure that filters and purifies the blood. And when I talk about tube-like structure, it's very, very small, teeny, teeny, tiny. And we have about 1 million of them. We're born with about 1 million of these nephrons. If the renal arteries are narrowed or stenosed, the body reacts by producing renin, and the renin is a hormone that causes those small arteries to narrow down even more. This kicks off that cycle of even a higher blood pressure, more diminished blood flow, and more damage to the nephrons, which over time, the kidney will no longer function as the filter that it was meant to be. So it completely loses its effectiveness, and the kidney damage becomes slowly irreversible over time. So what you see is this buildup of fatty plaque in the artery walls. You'll start getting this fibromuscular dysplasia, overgrowth of muscular tissue in artery walls, which is incidentally found in a lot of females. And what that looks like in these females, there's uh, somewhat like beading. It's like a cluster of pearls, and it doesn't happen frequently in everyone, but you will see if it does happen, it's going to happen mostly in females. So you're going to look at your assessments and diagnostics here. You're going to be looking at your MRIs, CTs, angiography, um, ultrasounds to see what those vessels look like around the kidney. The possible treatments we talked about was the angioplasty and stenting, the bypass grafting, but you also can do some antiplatelet medications as well. Pheochromocytoma is a rare and usually benign tumor that has to do with the epinephrine and norepinephrine. These hormones are constricting most arteries and they raise the blood pressure. This is the fight or flight responses we talk about a lot of times. In this, it causes tremors, nervousness, weight loss. People can faint from this overproduction. The treatment for this condition would include medications that block the effects of epi and norepinephrine. Surgery may be done to remove the adrenal gland tumor. The pheochromocytomas are extremely dangerous, and if they kick off, they can really cause an extreme rise in blood pressure that's very dangerous. Um, about 10% spread beyond the adrenals, and if the surgeon cannot remove the tumor, they can use chemotherapy or radiation therapy to shrink the tumor down. Shrink the spread, but it is something that if you've ever, they use a lot of steroids to try and bring that blood pressure down, bring that inflammation down, and it's sometimes you will see a if a person has not tapered off of steroids properly, you will see a similar response like a pheochromocytoma response to blood pressure. If someone has not tapered off of steroids properly, you will see this crazy blood pressure um, excitability and just massive rise in blood pressure above 200 systolic. It's very dramatic and it needs emergent attention. Hyperthyroidism is another problem where the thyroid produces hormones that control the body's metabolism. And sometimes these conditions and diseases can trigger overproduction of the thyroid hormone. And this causes hyperactivity. An example of that would be Graves' disease. Hyperthyroidism can cause high blood pressure, tachycardia, insomnia, intolerance to heat, excessive sweating, weight loss, and irritability. And the treatment to that is to suppress the gland's activity. And many times you can, as you're managing the blood pressure, you get the thyroid medication to suppress that gland's activity. A lot of time those symptoms will just restore to normal blood pressure parameters and normal functioning of the human body. You would not have all these issues once you get that thyroid under control. You can also do surgery. You can also do radiation treatments, that kind of thing. But a lot of times, just the medication alone will shrink the thyroid and also um, reduce the hormone production. If nothing else, they can actually remove the thyroid and regulate it through medication alone. Coarctation of the aorta. This is a rare birth defect where a segment of the aorta in the chest is abnormally narrow, and it may not be discovered until adulthood. Most of the time, when the baby's born, the nurses are going to assess that child very carefully, and they're going to be checking for symptoms of any abnormalities in the chest that have not been discovered prior to. They do so many tests now. But there are occasions where prenatal care has not been done in a pregnant female may not have had ultrasounds or issues, may come in and have a baby that has birth defect. And so they may not know that for sure until the baby is born. So nurses will be assessing that patient for cardiac anomalies, and one of those is this coarctation of the aorta as well. So you may be able to have uh, feel pulsation in that area, and you may be able to see that when they're a child. But sometimes it does not become apparent. It may be very small, but you're going to assess a patient if they are over 30 years of age. You'll be seeing that there could be a delay in pulses in the femoral area. They may be absent. Symptoms could be headache, fatigue, leg weakness, poor circulation or claudication, where you have this catching in the legs, and a continuous murmur auscultated over the back, chest, or abdominal bruit. So a screening test would be your echocardiogram, and that's going to be where you see the flow of the blood through the aorta. And this will be through a thoracic abdominal CT, angiography, or MRI, and they can do arteriography with the MRI. And so you can actually see the flow of that blood through those vessels. Cushing syndrome is a hormonal disorder that's characterized by overproduction of cortisol by the adrenal glands, and you know that cortisol is also produced by having an extreme amount of stress in your life, and so we try to eliminate some of that stuff, and we'll talk about lifestyle changes, which is part of that. But Cushing syndrome is something that is a little bit different than that. This is also production from the adrenal glands. Long-term use of corticosteroids. I just talked about that. But these are drugs that are used to combat allergic reaction or autoimmune disorders. So it could cause high blood pressure, weight gain and facial swelling, excessive body hair, you know, the buffalo hump, acne, diabetes, osteoporosis. And the treatment of overproduction by the adrenal glands involves this drug therapy or surgery. Long-term steroid use also requires that tapering I was talking to you about of dosages, and it has to be very carefully tapered, or you will have severe hypertensive problems. So Cushing syndrome is one of those secondary hypertension causes. Sleep apnea, about a third of people with hypertension have obstructive sleep apnea. And when we work in surgery and pre-op areas, one of the things that we screen for is undiagnosed sleep apnea, because we'll see patients that have this problem with obstruction, which causes hypertension in surgery, which can lead to stroke, which is part of this. Actually, what we do is we make sure that the patients, if they have been undiagnosed with sleep apnea, we give the stop bang screening, and we also give them options to seek counseling and a referral to talk to someone or have a sleep study or have CPAP or some kind of positive pressure breathing apparatus to make sure that they have no sleep apnea during the procedure or while they're in the hospital. Hospitals have CPAP or BiPAP or some of those different types of breathing apparatus. Patients can bring them from home, but if they don't have them, they can use them from the hospital as well. And that type of diagnosis is made when you find that the sleep apnea sufferers stop breathing 15 um, or greater than 100 times per hour. And it causes O2 to drop. So you'll see a significant drop in um, their O2 sats when we stop breathing. And they actually just stop breathing. It could be from a tongue obstruction. It could be from a malocclusion. It could be something where they have to have some surgery for TMJ or the jaw placement. They also could have a very long uvula or something like that that's obstructing the airway. They may have to wear a mouthpiece or something that's going to correct that malocclusion in their bite. But the body responds to this hypoxia by releasing epinephrine, a stress hormone that responds, and it will increase the blood pressure. And so you will see patients in this screening, they'll have necks that are greater than 17 inches, or women that have 16 inches or bigger necks, and it's basically they don't have any neck. It just goes like their head is basically right on their shoulders, or they'll have a class 3-4 malocclusion, or they have a palate that is misformed. So these all are setups for obstructive airways. They may also have what anesthesia may call an anterior airway, where as soon as they close their mouth will drop, their jaw will drop back, their airway is right there close to that, and they will start occluding almost immediately. So some people are mouth breathers, and they tend to occlude very easily as well. So some patients have never been told they snore, but that's just because their partner's trying to be very polite. But when people stop breathing, that's different than snoring. Most people would you would rather hear them snore than just stop breathing altogether. So but for diagnosis, they're going to refer them for polysomnography or home sleep apnea study, possible surgery, and there is a new implantable device called Aspire, where it will actually stimulate your tongue to move forward, and it as an electrical device that's like almost like a pacemaker, but it will stimulate your tongue to move forward, and it really you'll be asleep, and the thing will automatically sense that you're not breathing, and it will stimulate. And it's a two part procedure where they'll put the implantable in and test it and make sure that it's actually working. And then they'll come back and put the permanent device in. And you'll have a little remote control at your bedside. It has saved a lot of marriages, to tell you the truth. So, medications and other substances for secondary hypertension treatment, so many drugs that we regularly use can cause increases in blood pressure. And as you know, you have drugs that patients have been have had to avoid, and patients with hypertension um, have just gone through agony, especially males with prostate problems or enlarged prostates have had a lot of problems with taking medications that would cause their prostates to swell and have hypertension. So they have had suffered through colds or a sinus congestion, and just had to use salt water to be able to breathe. And so they have made medications to where people, you can see where it's for patients that are on blood pressure medicine or have had to avoid these medications in the past. So you know that there are drugs out there over the counter that you have to be careful for. So I'm going to go through some of those with you now. There's quite a few. This is probably not all inclusive, but this is the high spots for you. So certain medications prescribed for autoimmune diseases constrict blood vessels throughout the body, as do some other drugs used to treat cancer. And some examples would be corticosteroids or glucocorticoids, cyclosporins. Some of these drugs are used for prevention of organ transplants, so they don't reject them. You can look at things like enzalutamide or androgen receptor antagonists. Those are the prostate cancer drugs. Certain older drugs used to treat depression, including your MAOIs and tricyclics, also can cause hypertension. Herbal preparations like St. John's wort is when you mix that with MAOIs, they intensify the effects of MAOIs to the extent that it can cause very high blood pressures requiring emergency admission to the hospital. So stay away from St. John's wort if you're on antidepressants. It's just a safe word of warning. That's the one herbal preparation that seems to have a lot of interactions with prescription drugs on the negative side. Oral contraceptives can lead to higher blood pressure, mostly those with the estrogen component. They make those that are much less estrogen strong, but they still do cause hypertension over time. And those women who smoke, are overweight or obese, or over the age of 35, they are at high risk for hypertension while on oral contraceptives. And when women stop taking the pill, in most cases, the BP returns to normal. So we all know that there are dangers with taking oral contraceptives for very long periods of time. So they may have to change the type of oral contraceptive they're on or abstain from them for a while, use alternatives just to kind of detox their body until they can find a suitable alternative for that. But the longer they stay on oral contraceptives, the more they need evaluation for hormonal change to prevent hypertension and cardiovascular changes that could possibly lead to DVT or stroke. Other substances also play a role. Toxic environmental substances like lead and cadmium can also lead to hypertension, and we don't even know we're exposed to those every day in the water and the food and the micro doses that we take throughout our lives. Things that are in alcohol, caffeine, and other herbal supplements like ephedra, they can also raise the blood pressure. So I was surprised, and not that I'm a fan of it, but I know some people are they love licorice. Black licorice is listed in this group of substances because consuming too much of it, even in not even too much of it, but even small doses of it have been researched to showed that it can cause your potassium levels to fall. And it's because of this substance called glycosidic acid that affects the body's fluid balance. And it has this enzyme's effect on the kidney. So even modest amounts can raise the blood pressure. So be careful with your black licorice if you're prone to have electrolyte imbalances anyway, but watch that amount. Pain meds, NSAIDs, the only one that does not cause you any problems is usually your aspirin. But anything that you use, if you have hypertension already, and you put pain meds on aspirin, ibuprofen, naproxen, um, just about the only one that is not is suspected of raising the risk of heart attacks. So um, I think acetaminophen should be in that area instead of aspirin. I think that's what I meant to say. All NSAIDs except aspirin are at risk for that heart attack thing. Acetaminophen is up there mainly because of the liver problem, but you can still use it. It's just one of those things where you have to just watch your dosage of those things. Um, FDA in 2005 mandated a warning that's the side effect that said NSAID labels would be suspect of raising heart attacks. And in 2015, they even strengthened it even more because they had Vioxx that was on the market, and it caused 140,000 heart attacks over the 5 years that it was on the market. Celecoxib appeared to be less dangerous than other NSAIDs. NSAIDs tend to raise the blood pressure, probably altering blood flow in the kidneys, causing the body to retain more sodium and water. And they also change levels of substances in the blood that make clotting more likely. So a blood clot can cause narrowing in the artery in the heart and triggering that heart attack we talk about here. So if patients have a diagnosis of hypertension, they need to be cautious about using NSAIDs. If they need to take painkillers for an injury or a chronic condition like arthritis, they can consider other alternatives first, such as heating pads, ice, physical therapy if appropriate. They could try aspirin or acetaminophen, and keeping in mind that Tylenol can damage the liver, especially in people who drink alcohol. With any pain reliever, always take the lowest possible dose for the shortest period of time, and they can also contact their pain control management options or their provider for that. Also, things like your your gels uh, that you can put on your body can help a lot. So you can use some of those things if you want. Also, watch out for your recreational drugs, things like cocaine. Stay away from the bath salts, and your methamphetamines really will constrict blood vessels, cause you to go crazy, and do some interesting things. But cocaine is a massive vasoconstrictor, and it will cause your blood pressure to go really high, and it can cause massive heart damage. So in this particular slide here is the suggested management. It tells you about what you should avoid in as far as alcohol, caffeine, and that kind of thing. Avoid the alcohol amounts that you should have if you're a male or a female are different. Um, for the male, you can have 2 drinks a day, so it'd be like 2 bottles of beer, 2 cans of beer, 12 ounces each. So you can have 24 ounces of beer for 2 drinks. A woman, cut that in half. If you want to have a cocktail, you can have 2 shots of a whiskey. For a female, cut everything in half. If you want a glass of wine, men can have 2 glasses. Women can have 1 glass. So that's basically what they suggest. If you have a diagnosis of hypertension, that is about the amount of alcohol you can have per day. So I don't know if everybody drinks every day, but if you happen to do that, that's the maximum. If you consume caffeine, caffeine is a constrictor as well. There are some benefits to it, but you just have to monitor your intake. There's caffeine in other things. So when you are looking at tea, colas, all that kind of stuff that have caffeine in them, The 300 milligrams of caffeine or less if you have uncontrollable hypertension. Your 300 milligrams of caffeine is basically about 3 cups of coffee, and regular sized cup of coffee, not mega sized. Um, your NSAIDs or your pain control, your Voltaren gels, um, diclofenac, uh, or other topicals can work really well. Avoid oral clonidine. I know there's been some stuff about clonidine, but they're considering in the new guidelines discontinuing use unless it is something for major hypertensive emergency. They're looking at some other drugs for rejection of donated organs. So if you're having transplant rejection, instead of cyclosporine, they're looking some other things to help with that. And also therapy, behavior modification, and lifestyle modifications are all part of the treatment plan to help with that. As far as looking at your birth control, the lowest effective dose of estrogen agents, or going to strictly progesterone agents, barrier protections, abstinence, or having a hysterectomy, that type of thing. Those are the things that you can do, drastic measures. So from the most conservative to the most drastic are there for suggested management, whatever works for the patient and their choices. So other types of hypertension that we may be talking about, and in your book talks about white coat, it talks about masked, it talks about resistant hypertensive emergencies and labile. The white coat is when you go to a doctor's office and you all of a sudden you feel fine, you just all of a sudden they take your blood pressure and wham, you have a blood pressure highest you've ever had in your life. So white coat can be influenced by being in an office and it makes you nervous to go to the office and you have a phobia about being in a doctor's office. So about 1 in 5 people can become very nervous in healthcare settings, and that can be seen in higher blood pressure settings. And if patients' readings are taken at face value, the patient may be subjected to unnecessary treatment because you're just looking at numbers. And so what they suggest to do is to use some strategies to allow the patient to relax and calm down. Um, Warm up. You always, when you go to the doctor's office, you always seem to be freezing, cold, nervous. All those things weigh. They're yelling your weight out down the hall, and you're very nervous and very upset. You don't want anybody to know that you're overweight. You don't want anybody to know what's going on with you. You want privacy. So the stress of just being there and people finding out about anything that's going on with you can just really upset you. So, the big thing for medical assistants, nursing assistants, or nurses that are assessing patients in these doctors' offices now is to get them to deep breathe and just to take that moment while they're in that sitting area by themselves to just meditate and relax and give themselves about 5 minutes to just sit there and relax and to concentrate on something pleasant. And fear of the unknown, they're there for a reason. It's not always a good reason to be in the doctor's office, but to concentrate on just their breath and breathing and to use that before they take their blood pressure. And when they do that, their blood pressure and their heart rate will slow down. They'll take the blood pressure in both arms, compare the two. Most of the time, when you go in there, they take it very quickly. They do it in one arm, and that's all. But the guidelines actually ask you to take it in both arms just to give a chance 1 or 2 minutes between each arm while you're setting up the cuff to go from one side to the other, and allow that time to check your blood pressure and see if there's any differences in either side. The masked blood pressure is opposite from the white coat. This is where your blood pressure is higher at home. You go to the doctor's office, your blood pressure's fine, but you may get home and your stress is so high at your home settings or outside of the healthcare setting that you are just hit with all kinds of things that you have to handle. And you have very poor coping mechanisms, don't have a good handle on what's going on. You're hit and bombarded with everything that you have to do. You're running around like a crazy person working 2 or 3 jobs. and your blood pressure is out of control and you're not being treated. So your blood pressure may not be taken at home. You've probably never taken your blood pressure at home, and your blood pressure is much higher. This means that the treatment that you received or that you may not be getting is because the blood pressure taken in the office, you were able to sit there and relax in privacy and quiet, which you wanted, and you're not getting at home. And so now you're missing treatment. So on one hand, you're getting too much treatment. On the other hand, you're getting too little treatment. The possibilities are just completely opposite. So you want to make sure that you get a blood pressure cuff type of a monitoring device that you can send home with the patient to make sure that they can take their blood pressure at home. This usually happens with older people when they first get diagnosed with hypertension, but this can be for anybody. Highly recommend getting a automatic device, battery operated, that is approved by a medical company, and maybe $50, $70 or something like that. But it's something that you can put on your arms, very easy to put on, doesn't require a stethoscope. Put it on and you can record it. And you record it, do it early in the morning when you get up, after before you have a cup of coffee, before you do anything, take a blood pressure. And then take it before you go to bed. And just do it twice a day. That's all. You don't have to take any more than that, and just see what your blood pressures are over a period of time. If you are having symptoms, and the doctor may ask you to do this for a period of 3 to 6 weeks, just to see if you have masked hypertension that has gone untreated. And resistant hypertension is exactly what it says. It's, no matter what, you are doing everything. You're the perfect patient. You're using the perfect diet for cardiovascular disease. You are limiting your red meat. You're doing less fat. You are exercising. You are reducing your weight. You are doing everything you can to limit your sugar intake. Whatever they ask you to do, you're doing it. Um, Even when you're on 3 to 4 antihypertensives, a diuretic being one of them, um, you've changed your lifestyle as far as learning how to relax. You've gone to meditation classes, you take yoga, you do all these things. Your blood pressure's still high. So these are people that are resistant, and we have to figure out what else is going on with them. And this occurs about 1 in 10 people. Those that are highest risk are the older patients that have the more chance of having atherosclerosis. They have the hardening of the arteries, so you speak. They have stiffened ventricles. Um, they have possibly more kidney disease or diabetes. So you have to watch for that. But that's one of those things where if we catch this earlier, we can prevent some of this resistance. Labile blood pressure occurs when blood pressures fluctuate more than usual. And there's always fluctuations with stress, fear, anxiety, too much going on. Things usually happen in threes where you just get bombarded with things that happen in life. But when we're talking about the labile nature of blood pressure, we're talking about over years rather than short term. This can be very damaging, and if unreported, can be difficult to diagnose until target organ symptoms start to appear. So the wear and tear of this jarring of this blood pressure going back and forth, just very volatile, is damaging to your blood vessels. So you're going to see this up and down, very difficult to manage. This could also happen why I say it's hard to diagnose is because you don't know how adherent your patient may be to taking their medication. Is it because of the medication? Is it because of an underlying physiology? We don't know. If they can't be on a stringent routine with their medicine, and we can't monitor them properly to make sure that it's not the medication, or the medication is not working for them, and we're constantly changing the medication, we can't make a very good evaluation of their treatment. So they can be really damaged, and then we run out of medications to give. So we got to find if this is a behavioral problem, if there's some other issue that's causing them to have this issue with the variability of the blood pressure. It could be their adrenal glands. We don't know. We have to look further. It has to dig deeper. Hypertensive emergency is a rare, but a further organ damage to the patient has occurred. Care has to be taken not to hypoperfuse these major organs. These patients have had hypertensive numbers that have been high for a while. And so if you all of a sudden just completely drop them down to low numbers, you could cause more damage than good. So the new guidelines, even the older guidelines, even as old as I go back to, we never drastically drop them down to what would be a 17-year-old person's blood pressure. Oh, no, no, no. They can't handle that. Their blood vessels are resistant and damaged. Remember that. And so if they have narrowing of vessels due to plaque formation, that heart has had to pump extra hard to get past that peripheral resistance. If they have diabetes, if they have problems with just getting blood through those vessels, if I go and drop their pressure down to 90 to 110, that blood flow is going to shut off peripherally. It's not going to get there. So I had to be very careful how I drop that blood pressure. And so you're going to be getting their blood pressure down below a safe number. You're going to be looking at dropping numbers down to 140 in the first hour, 120 the first hour, but you're not going to go to you're not going to go to 90 or 100. You're just not. So you have to look at making sure that, yes, you want to get that dangerous hypertensive situation under control because you don't want that patient to be at that risk of blindness or heart attack or stroke or kidney rupture or failure or liver failure. I mean, you don't want those, but you do want to make sure that you maintain enough blood volume and oxygen to those vital organs to perfuse them adequately. So when we talk about the target organ damage, if I have somebody who has a dissecting aortic aneurysm or some other rapid onset of organ damage, anyone who experiences this situation has blood pressures over 180 systolic or diastolic above 120, you have these immediate and rapid focused assessments. You don't play around trying to figure out everything that's going on. This is a high mortality and morbidity situation. It's emergent. They know that statistics show that when they have episodes like this, within that first year, that patient is more than likely going to pass away. It is very likely that this patient is not going to make it past a year. So the new guidelines recommend that this patient is immediately admitted to the ICU for constant monitoring and for IV administration of appropriate antihypertensives so they can regulate it, micro regulate, get it down below 140 for most conditions and 120 for aortic dissection in the first hour. So these are the things that you look at that are a little bit different from somebody who's just walking around with a blood pressure of 140, 160 over 80. You're talking about 200s, 300s, sometimes, just terrible hypertensive crisis. So home monitoring is the best option for patients when they're seen in the office and they're noted to have hypertensive numbers. And so the first thing you want to do is just if they continue to have high numbers in the office or um, they continue to have symptoms, give them. A lot of times they'll have coupons for insurance will cover it, Medicare will cover it, Medicaid will cover it. Um, they could get monitoring devices, and the pharmacy can help them with that as well. Your pharmacist is a good resource for anything that you can do to help take your blood pressure on the spot. The 2025 guidelines do not recommend wearables for blood pressure, that like the little rings or things like that right now. They say the technology is not there yet to be consistently accurate. It will be there in the future, but right now, there's still advances that are needed to be global. The recommendations are that they want to be authorized and validated oscilloscopes that are battery or automatic. And the reason they wanted to be automatic rather than dealing with stethoscopes and all that is the layperson is not able to handle all of those fumbling around things with tubings and pumping up and the screw thing on the pump, and you lose the screw, you screw it too much, lose the little screw thing, then you're shot. It's just trying to crawl around the floor trying to find stuff that's falling apart. The automatic is the way to go. You can have wrist ones. The ones on the fingers, they don't recommend. They do recommend one that goes around your upper arm if they have it. But you have different people that have different body configurations. So whatever works that is approved and validated. Amazon sells them, and most of your insurance for over 65 will cover a lot of those devices. You just have to check your plan. And I know that a lot of Medicaid Medicaid will cover it, and a lot of Medicare places will cover it, and a lot of private insurance will cover or have you spending over the counter spending plan that will cover it as well. So despite how we were born doesn't mean you just give up and let go of the goal of health. Awareness of the factors can help you put cardiovascular risk profile into view and may give you your extra incentive to adopt healthier habits. And some of the things that we cannot control or non modifiables are things that run in your family history of stroke, MIs, kidney disease, high cholesterol, lipids, increases in risk developing hypertension. Genetics provide a partial explanation because how we are influenced as children, our parents, or show us our eating patterns, our coping skills, healthy and unhealthy habits are part of our social history as well. So it's not just genetics, it's how we are raised. So research has discovered dozens of gene variants, and some of those are linked to both hypertension and damage to tissue in heart and blood vessels. But these links are extremely variable. Age does not always lead to hypertension, and it does become more common later in life. But uh, the weird phenomenon is your diastolic blood pressure increases gradually over the years by about 10 millimeters of mercury until about 55, and in men, 60 in women. Then it starts to decline, and between 30 to 65, the systolic blood pressure increases about an average of 20 millimeters mercury, um, and it continues to climb after 70 years. This increase over the years explains the isolated systolic hypertensive type that we talked about at the beginning. Gender considerations: about 55 women, about the age 55 women are less likely to develop hypertension than men, but after that they shoot up in very sharply than that of men. So after age 55, women are at higher risk for hypertension, and this pattern may be partly explained due to the decline in hormone estrogen levels. Those protective properties are gone or waning, and so as those estrogen levels decline, women lose that benefit. Race, to me, it's always been quite puzzling why certain races have the propensity for renal and other vascular diseases. Blacks, African Americans, and I say blacks because all blacks globally often develop hypertension earlier to greater degree than do people of other races. And while they're about 40% more likely to have hypertension than Caucasian or European, they are significantly less likely to have it under control. And there are some researchers that talk about some scleroderma, some issues with just and anatomy. And so genetics may be partly a cause, anatomy may be partly a cause. Psychosocial factors such as discrimination, racism are also recognized as stress factors. Long-term studies suggest that discrimination from employment opportunities, where you live, safety, healthy food access, medical care access, all increase the risk of hypertension in the African American population per se. So social determinants of health are really, really big. And what if you had to look at two ongoing major studies about that, and if you think that's not true, you need to open your eyes. Two current ongoing major studies are worth noting. One is Jackson Heart study that is ongoing right now This is happening in Mississippi. There's about 5,300 participants that are currently enrolled in this atherosclerosis risk and community study. And this takes in specifically African Americans aged 35 to 84. The second one is a multi-ethnic study of atherosclerosis that includes over 6,000 racially diverse people. This provides a 10-year risk calculator um, tool which clinicians can use to determine risk-based treatment plans and improves that communication using quantifiable accuracy when you're trying to diagnose cardiovascular uh, propensity in these racial and ethnic groups. And what you're taking is Chinese, Caucasian American, African American, or Hispanic populations. New, interesting thing too about the prevent, and I was talking about earlier, one of the things they're trying to do is to eradicate race as a defining factor in cardiovascular risk determinants. They want it to be a permanent social determinant of health in that anybody of any race can have cardiovascular disease because it's going to be such a big thing by 2050. So they don't want to just target one certain patient population. They have found that some of the things that we do from lifestyle modifications work for everybody. And so they want some of these things to uh, be a global type of thing and not just one particular patient population. So that's how research works, though, folks, is that they start with a certain patient population because it's reachable and doable. And then they move to these huge research, ongoing research studies that follow patients for 20, 30 years. So these two studies, I highly recommend that you look these up and pay attention to them because this is going to affect your future. And you're going to hear a lot more about them. So the risk factors you can control. Health habits are key factors in determining your cardiovascular risk. Patients should know that they'll be able to overcome the effects of other risk factors and can reduce their blood pressure readings into a safe range by doing these things. And these things seem insurmountable for some people. This would be reducing your salt intake, reducing weight, stopping smoking or nicotine intake, um, exercising. I mean, it just seems like a cliff that you cannot climb. So when you're talking about obesity, excess weight, hypertension go hand in hand because carrying even a few extra pounds forces your heart to work harder. And whenever you have to do an autopsy on someone who is morbidly obese, their heart is surrounded in layers of adipose tissue. And so if you can imagine the muscle underneath that adipose tissue trying to pump blood, it's almost impossible because that heart had to work extra hard to pump against all the fat that was around the heart. So being overweight increases the risk of heart high blood pressure approximately times. The risk continues to rise as the body mass index progresses into the obesity range, and by contrast, systolic and diastolic pressures drop an average of 1 millimeter for roughly every pound or two of weight loss. So, although the actual amount varies from person to person, um, if you can think about that in terms of numbers and you can help tell your patient that if you lose a pound, you lose a point, millimeter of mercury off your blood pressure. Every time you lose a pound, you're losing points off your blood pressure. Sedentary lifestyle. Compared with physically active people, those who are sedentary are more likely to develop hypertension and suffer MIs. And like any other muscle, the heart gets stronger with exercise. And the thing about exercise is you have nitric oxide that is produced. It makes your heart go faster, but it also expands your blood vessels and it carries nitric oxide, which is something that allows your blood vessels to dilate. And when that happens, more oxygen gets to your blood vessels, and that's what that's supposed to do while you're exercising. And so um, it pumps more efficiently with less force through the body when it's stronger. Other benefits are raising the HDL levels and decreasing those embolic events. And we could talk about smoking. Long known as smoking promotes heart disease, but for many years, trying to quit smoking is like trying to kick heroin or a cocaine habit. It's very, very tied to not only social, but it's also tied to just a habitual nature of having a cigarette. And it is tied to eating. It's tied to events during the day. It's tied to drinking alcohol. It's tied to coffee. It's tied to things that you do. It's tied to breaks. It's tied to all kinds of things. So people use it to think. They use it to um, have privacy. They use it to just take 10 minutes to themselves. So, but smoking causes problems and damage to your heart. And when you think about the younger age people, doesn't matter if you smoke, vape, chew tobacco, smoke cigars, it doesn't matter. It's the nicotine. The nicotine constricts blood vessels, and what it does is every time that you use it, you're getting those highs, peaks and valleys of blood pressure, and it lasts for several hours after you use the nicotine. So instead of having just an even keel of nicotine going on all the time, you're having these peaks and valleys, which releases the nicotine, releases epinephrine, that stress hormone, which causes your heart rate and blood pressure to go up while you're absorbing that nicotine. Excess salt in the early 1900s, doctors discovered a link between salt and hypertension. They found that when they restricted salt in people with kidney failure and severe high blood pressure, it brought those blood pressures down and improved kidney function if they just brought the salt down. A massive education effort began back in the 60s to inform everybody that lowering their risk for heart disease and lowering salt, reduced blood pressure was part of that education. Instead of the amount of knowledge shared, the desire for that convenience food, eating out, McDonald's, and getting more money. We were able to eat out more, the restaurant. Everybody was working more. Didn't have as much time to prepare food at home, eating fresh at home. We ate out more. It was easier. So the consumption of sodium was better. More convenience. We ate more canned food. There was more sugar and sodium in canned food. We started ingesting a lot more sodium. So that was why our blood pressures rose as well. Heavy drinking, 3 or more alcohol drinks in one sitting, temporarily increases your blood pressure. And over time, excess drinking, including binge drinking, can have longer lasting negative effects on blood pressure. Binge drinking is having a blood alcohol of 0.08%, which typically happens when a male has 5 or more drinks or a woman has 4 or more drinks within a 2 hour period. Heavy consumption of alcohol can interfere with antihypertensive medications and can increase your risk for stroke or MI. And I can't even begin to tell you how it interacts with pain meds, can't tell you how it interacts with antidepressants and other medications for ADHD. Combining those things can be a deadly cocktail. So, how hypertension harms your health? Um, It works on the brain, it works on the eyes, it works on the cardiovascular system, works on kidney and diabetes, the metabolic area. So when we talk about the brain, we're talking about the risk of stroke, whether it's ischemic, hemorrhagic, or those TIAs. And this is what's so interesting because hypertension plus diabetes increases your risk for developing Alzheimer's and dementia. Your eyes, hypertension increases the risk of loss of vision or even blindness. And we'll talk about how this works, but this is just an overall thing. Your cardiovascular system, we talked about atherosclerosis, but also we're going to be talking about atrial fib. We're going to be talking about heart attacks and stroke, and we've talked about those atrial fib and, and MIs in previous lectures. In the kidneys, we've talked about the renin angiotensin system, the RAS system. Hypertension increases the risk of kidney disease and kidney failure by destroying the glomerular filtration system and our beloved nephron. And then in diabetes, hypertension increases the risk of diabetes, and it's the microcirculation. So when high blood pressure makes blood vessel walls more susceptible to atherosclerosis, to buildup of fatty plaque, it leads to inflammation, which in turn encourages that fatty and fibrous substance to accumulate. And as plaque is deposited inside those artery walls, they become narrower and blood flow is reduced. And we've talked about this in the past. But this causes the heart to work increasingly harder to drive blood through the body, and as a result, the left ventricle becomes thicker and more muscular, and it tries to contract with greater force, and that phenomenon is known as left ventricular hypertrophy. This eventually is going to become counterproductive. As the heart muscle enlarges, it needs to produce more oxygen, but the coronary arteries, which are also thickened and narrowed due to hypertension, they become less able to deliver it. And the lack of oxygen could cause angina or chest pain, and if severe enough, a heart attack could cause that infarction. The combination of that left ventricular hypertrophy and diseased coronary arteries, aided by hypertension, can also lead to heart failure. And those with uncontrolled high blood pressure, believe it or not, are twice as likely to develop heart failure as someone with normal blood pressure. So it's extremely important to get blood pressure under control, which is why we're honing in so much on this particular topic. But unlike the biceps muscle, if you can imagine how you muscle people, muscle builders are trying to build up their muscles, the heart muscle doesn't work like that. Um, Biceps will grow larger and stronger when somebody lifts weights. They increase the thickness of the muscle. It doesn't translate into strength like that. In fact, as the blood supply fails to keep up with the muscle's growth, the heart gets weaker and is subject to either of the two main kinds of heart failure. One is heart failure with reduced ejection fraction, and that arises when the heart cannot pump forcefully enough to push a sufficient amount of blood into circulation, or heart failure with preserved ejection fraction, where this when the heart cannot properly fill with blood because it's stiff and it has trouble relaxing. So heart failure symptoms that you're going to see could be weakness and fatigue. Fatigue is a big factor with any kind of heart problem, period. Shortness of breath, fluid buildups known as edema in the lungs, feet, ankles, and legs. Left-sided failure is drowning. Right-side failure is blowing up or swelling. So just remember that when you have left-sided failure, if you look at a patient and you see them with pulmonary edema, they're coughing up frothy sputum, um, their lungs are full of fluid. You can hear crackles and rows. You know that they're in heart failure. You look at them and tell that they're just drowning in fluids. The right side, they're just swelling. It's a complete difference. They're not their lungs are not filling up with fluid. They're just swelling everywhere else. Their feet have pitting edema. It's just one of those things where you've got to really look at the patient and you can tell what you're going to be getting into. So long-standing uncontrolled high blood pressure is the most common cause of atrial fibrillation, which usually develops after age 65. And people with atrial fib experience periodic spells during which the upper chambers of their heart just quiver erratically, like a bowl of jello. And as a result, blood swirls around and pools inside the upper chambers, and they may form clots that can cause a stroke if they break loose and make their way to the brain. Atrial fib increases the risk of stroke about 5 times. And in that Framingham heart study that we talked about last week or so, atrial fib was blamed for one of every 4 strokes among people over 80 years of age. It also is one of those factors after an MI has occurred. Atrial fib tends to be one of those lingering heart rhythms that is indicative of a previous MI. So it's one of those things that is a warning sign. So taking medications that prevent blood clotting, like anticoagulants such as warfarin, Coumadin, Xarelto, or Pradaxa, or Eliquis, can reduce the risk of stroke by more than 2/3 in people who have atrial fib, as well as other stroke risk factors. However, treatment with any anticoagulant carries risks for these patients, and so there is a risk of hemorrhage. So you just have to watch out for that. But um, that Framingham study that we talked about, that's a good source of information for you to look at because they look at that study for heart failure specifically. So more than 2 out of 3 adults with diabetes have high blood pressure or are taking blood pressure drugs um, like hypertension. Diabetes increases the chance of having a heart attack or stroke, not to mention kidney disease, eye damage. Having both diabetes and hypertension raises the risk even more. And if you add drinking alcohol to heart disease, diabetes, smoking, alcohol, it's pretty much a loaded gun. Insulin issues also play into people with diabetes and cardiac disease. They have too much circulating insulin, hyperinsulinemia. Um, the mechanism of this insulin link is thought to raise blood pressure in two ways. They cause the kidneys to retain sodium, and they prompt the sympathetic nervous system to release chemicals that constrict blood vessels. So, the cardiovascular disease prevalence over time, most people with diabetes develop problems. About 65 to 75% of people with diabetes die from some type of cardiovascular disease, and that is a rate 2 to 4 times greater than non-diabetics. So current blood pressure guidelines advise diabetic patients or chronic disease kidneys or those with chronic kidney disease to take meds if their consistent BP recordings are 130/80 or greater. And in addition to these high antihypertensives, they got two classes of diabetic medications that can help reduce the risk of serious cardiac complications and death. And these are game changers. These are SCL2 inhibitors and GLP-1 receptor agonists. And you hear these advertised all the time. These are going to be your drugs like your SGL2 inhibitors. These are the classes that are used to treat type 2 diabetics. These work by preventing the kidneys from reabsorbing glucose, which leads to increased glucose excretion in the urine. Some of these drugs have been approved only for uh, diabetics, but some have been approved for both diabetic type 2s and heart failure and chronic kidney disease, all three. So the drugs that have been approved for those have to do with Farxiga, Jardiance, and Invokana. So these drugs can effectively manage type 2 diabetes, reduce the risk of major cardiac events and heart failure hospitalizations, and also if they have chronic kidney disease, it can slow the progression of the kidney failure. So these are super great game changers for them. The next group is the GLP-1 receptor agonists. These are the ones that you hear about Ozempic and Victoza. These are the ones that help you lose weight. These injectables, the first set, the SGL2s, those are um, oral medications. These are injectables. These include Ozempic. A pill version of semaglutide Rybelsus is available. I'm not sure how widely available it is, but they mimic the effects of the GLP-1 hormone that help regulate blood sugar by increasing the levels of insulin in the body soon after eating and make people feel fuller longer. And some people that have been on Ozempic, they just forget to eat. And so you have to remind people that are on these drugs, they have to eat something. They have to put something in their calendar. You need to eat something because they forget to eat. They just they lose their appetite. So it leads to modest weight loss for about 4 to 7 pounds. The GLP-1 receptors are in baroreceptors throughout the body and also counteract that renin-angiotensin system and the sympathetic nervous system response, producing a reduction in the systolic blood pressure. So there are resources in the back of the slide presentation if you want to look that up. But seriously, these drugs are game changers uh, to help with not only reducing weight, helping with blood sugar, but also helping with blood pressure control as well. So I just this is something that's almost incredible to watch how this is helping with blood pressure control. So chapter 27 goes into a lot of gerontological considerations, but current research connects hypertension and dementia, which I find pretty interesting. That studies estimate that more than 9 million Americans can have dementia by 2030 and nearly 12 million by 2040. And mild states of cognitive impairment, or that transitional state between normal aging and dementia, is expected to markedly increase. So hypertension can have a hand in the onset of dementia by accelerating atherosclerosis. And when you think about how that atherosclerosis impairs the circulation and causes a lack of blood supply because of the narrowing of those vessels, it can produce small areas of dead tissue in the brain. This can cause loss of memory and thinking skills that interfere with daily living. So, tiny strokes, I mean, microscopic strokes, can occur over time. These incidents of damage can be so small that the symptoms may not be noticed until a substantial portion of tissue in the brain is destroyed. And this condition is known as vascular dementia. About 5 to 10% of all types of dementias fall in this category. So, a tenth of them. So, it's well recognized that it causes a lot of, when you get older, you start losing your memory loss. And it's something that we just tend to brush off with as a sign of aging. But the link between this vascular dementia and hypertension, um, maybe something that we used to brush off as a sign of aging, but we probably should be taking more attention to, because people suffering from dementia often have normal or low blood pressure. So, long term studies now show that high blood pressure in midlife or in your 30s and 40s may predict poor brain function in older age. So, even slightly elevated blood pressure in middle age has been linked to a 30% higher risk of dementia 20 years down the line. So, high blood pressure also appears to harm memory by damaging the brain's white matter. And white matter are the bundles of nerve fibers that connect brain cells. So, changes in that white matter occur to everybody over the age of 60 at some point. And so, they also contribute to normal age related memory loss. So, we don't need any more help from hypertension. So, damage to white matter is more extensive among people with high blood pressure. Key cellular and molecular mechanisms that are causing this to happen are endothelial dysfunction, your blood-brain barrier dysfunction, and oxidative stress and neuroinflammation. Those together cause this white matter changes. And I've seen lately on the med-surg floor diagnosis of white matter um, disease, which is pretty interesting. I've never seen that before up until just recently. So something to keep your eye on. And as we see, this is going to be a huge increase. Um, this slide shows you how the molecular structures and the pathology works. So just thought you would like to see that. The good news is that controlling the blood pressure can lower your risk of dementia and slow progression. So monitor your blood pressure, tell your patients to monitor their blood pressure, get that home monitoring system. So other diseases we were talking about with hypertension have to do with the kidney disease and your hypertensive retinopathy, and that's your eye diseases. Kidney disease is sustained high blood pressure damages the glomeruli. We talked about that, and we talked about what it does to that. It causes the kidney not to be able to filter waste and excrete sodium and water, and this damage is one of the most common causes of kidney failure. The weird thing about these two together is that chronic kidney disease it is a predictive. It predicts severe hypertensive retinopathy. So when your kidneys fail, it also is going to tell you about your eyes. The eye works by focusing visual images into the retina. And this is a sheet of nerve tissue at the back of the eyeball. Um, and it immediately is behind the retina. It's a network of tiny blood vessels that keeps this tissue richly supplied with oxygen and nutrients. High blood pressure can cause these arteries to narrow or break and bleed into the retina. It can lead to swelling of the optic nerve, which carries images to the brain. And most people with this problem do not have symptoms The biggest symptom that they may have might be a headache, or they may have some, blurring of their vision. But, when you have a headache or you have a migraine, that's what people think about a lot. So untreated hypertension can lead to loss of vision and even blindness. So you have to go to a doctor, and you have to have someone who can use an indirect ophthalmoscope to look to the back of the eye, to the retina, and do a fundoscopic exam. Somebody that's experienced in being able to look in the back of the eye and see these blood vessels back there. Small infarcts will appear like white spots. They're called cotton wool spots. There may be some hard exudates, which would be fat deposits like your cholesterol. There may be some copper or silver wire showing where those blood vessels, which are real tiny, like little road, they're shrinking or hardening, and they're crisscrossing each other, so they're actually changing direction. Swollen optic disc is where you have papilledema or fluid accumulation, which is putting pressure on the optic nerve. And you do not want to put pressure on your optic nerve. That leads to blindness. So when we talk about these guidelines and why it's important to follow the guidelines, it's helping to diagnose with high blood pressure. The national and international guidelines offer research and evidence-based recommendations for measuring and managing blood pressure for a variety of conditions and situations. And not following those guidelines can delay treatment, provide unnecessary or outdated treatment, and medications that may or may not have the best outcomes. And there's new non-traditional treatments that may help with dietary or lifestyle modifications that can work as part of a holistic plan of care. And patients should be aware of the latest information available to them, especially if they have hypertension or any of the comorbidities that are associated with hypertension. So the first step is a proper diagnosis, is accurate measurement of blood pressure, because the blood pressure varies throughout the day. Hypertension is rarely diagnosed on a single reading. And so instead of that, you're gonna need to have multiple measurements on at least two occasions, usually within a few weeks of one another. The exception to this rule is for blood pressure readings of 160 over 100 millimeters of mercury or higher, especially if you have underlying symptoms of another disease. So the result for this calls for prompt treatment. So you're going to be checking blood pressures regularly on a patient that has blood pressures this high. Um, you're also going to want to make sure that patients understand that monitoring of blood pressure um, is a good thing to do as a routine basis. You don't want to overdo it, but become a hypochondriac with it. But you do want to if you're having symptoms, you want to measure it. If you want to learn how to listen to your body telling you what cues you're having and being able to report that. And with the advent of the internet becoming more available in rural areas, telehealth, and with people having computers and apps and the ability to get on their phone and transfer information, it's much easier to transfer some of this data, uh, recording blood pressures to the doctor directly through something like a MyChart through Epic or another type of app that is used to convey patient information across secure websites. Short of a hypertensive crisis, which can cause chest pain, nausea, seizures, high blood pressure has no warning signs at all. Patients may completely be unaware of it. Blood pressures need to be checked regularly to look for trends. How often should you check it? Well, in general, blood pressures from 160 over 100 to 179 or 109 should be rechecked within 1 to 2 weeks, or with 1 to 2 weeks, while measurements are from 140/90 over 159 over 99 should be repeated within 4 weeks. People with stage one who have never, had a problem before, um, they should be rechecked 4 to 6 weeks. 130 to 139 systolic or diastolic of 80 to 89. They need to be checked every 4 to 6 weeks. So the higher your blood pressure, the more frequently you should check it. That's basic. People with a normal reading of less than 120 over 80 should be rechecked annually. However, follow-up visits could be sooner depending on if you have other problems. If you've had a previous blood pressure measurements were considerably lower, uh, if signs of damage to the heart, brain, kidneys, or eyes are present, or if positive for cardiovascular risk factors, most doctors will routinely check blood pressure at every office visit, period. So, um, you're going to be looking at those parameters to see when when your patient should get their blood pressure checked. So which arm should you get checked in? Well, it's a good idea to check it in both arms because you want to see if there's any discrepancies. One arm might be higher. If you're right hand, usually on the right side, it's a little bit higher because you have more direct right blood flow from the right heart side on that side. The higher number, remember, should be used to make treatment direct decisions, not the lower. So you've now made a diagnosis of hypertension. So what are you going to do now? Um, Inquiring minds want to know. You, as a nurse, need to know more about this patient. I tell you this all the time. What are their habits? Instead of using the word compliant about medications, you need to talk about words like adhere or commit to or stick with. You're going to be giving medications and educating patients about what they are taking and why they need to take them. Regardless if it's an essential hypertension or a secondary cause of hypertension, the patient's going to be on medications. And depending on how well they will stay on the medications will determine the overall improvement and our evaluation of that treatment. So, one thing to use as a carrot if and when they adopt lifestyle changes and start seeing positive results in the short term, they may see some of those dosages of medications reduced or eliminated. It sometimes works that way, but you got to talk to them in terms of if you tell me that I'm non compliant, it makes me seem like a difficult person. I don't want to be difficult. I just don't understand the situation sometimes. So, you've got to figure out what's going on with this patient. So be like the National Enquirer and dig around and figure out what's going on with them and how you can communicate best to get them to work with you on this treatment plan. As a med surg nurse, to know that you're establishing a short term relationship with the likelihood that you will see this person again at some point, you're not the one doing the full fledged history and physical on this patient. This has been done before. And so you're seeing them for a short term, maybe for a 12-hour shift, and you may not see them again. Or you may see them the next day. So you're establishing a short term relationship with the likelihood that you're going to see them again at some point, and your ability to connect and provide education is going to offer a bit of information that will practically add to their life and positively support them during setbacks or during illnesses or will give them benefits to them and their caregivers. You're going to play a big role in their life. So, home health nurses play a role in their life. Advanced practice RNs, like nurse practitioners, play roles in their life in screening and communicating and following up with them. Other members of the care teams, which depend on patient needs, can include PT, your OT, your cardiologist, your dietitian, nursing, primary care, MD, a pharmacologist, your medical assistants, ophthalmologist, the list goes on and on. But these are the ones for hypertensive patients. Those are the ones that you're going to be looking to for other specialties. What I want you to get out of this slide is the rationale. Why are you asking? What are you doing this for? And what is it going to give? What is the goal that's going to be given to the patient? So, for me to tell you to do these things seems like a lot of information, and it is. But when you start putting together the connection of why you're doing it for the patient, this should give you some understanding of the whole picture. So it helps to understand the whole picture. And this is what beginning point of nursing pre-licensure nursing is doing is getting you to start building that whole connection and building that um, picture of the patient as a total package. While we're still talking about diagnostics, we're looking at medical tests. And so for hypertension alone, I mean, anytime you come into the hospital in an emergency situation, they take tons and tons of tests. Let's focus on the hypertension and what are we going to be looking at? We're looking at lab tests that are specific to help us target organ damage and screen for primary or secondary hypertension here. So our urinalysis is going to be important because we're going to be looking at protein or blood in the urine. That could be a sign of kidney damage, while glucose in the urine could suggest diabetes, of course. Blood and blood chemistry, we'll be looking at specifically for sodium, potassium, chloride, calcium, bicarb, glucose, and cholesterol. Or BUN, creatinine, are indicators of kidney function. The cardiac, our 12-lead EKG, gives a picture of electrical conduction of the heart and the heart's general health. Our basic EKG or ECG is used to compare new signs of coronary artery disease or changes in the heart wall, like ischemia or infarction or history of such a thing. Our echocardiogram can measure left ventricular hypertrophy, valvular disease, heart failure, any kind of turbulence in the way our blood's flowing, our ejection fraction percentage, what's left in the ventricle after the blood is pumped out of that heart. Stress testing, assessing how the cardiovascular system responds to exercise, whether you are doing it. If this patient comes to the hospital, they're usually very sick, so they're not able to get up on a treadmill and run like in a cardiologist's office. We're talking somebody that's on a stretcher, not feeling well, blood pressure out of control. They could take them, get their blood pressure down. They could put them, after they stabilize, into a nuclear or chemically induced stress test that can reveal problems that aren't evident when patients don't exercise. Maybe these are people that have not exercised in 20 years. You're not going to put them on a treadmill. So they may just chemically induce them with medication or through nuclear med. Holter monitors, these are things that are kind of like your telemetries. These are things where patients can ambulate and move around, and they're looking for aberrancies. They're looking for fluctuations in their rhythms. They're looking for any kind of abnormalities that they can capture in real time, and that's why they put patients on telemetry monitoring. At home, they call these Holter monitors, where they go home with the same type of telemetry box, and these things are streamed to the doctor's office over time. They are recorded. And so the patients are instructed on how to record those to the doctor's office and transfer it over. Um, they also can do this for blood pressure as well. And so I'm not as well understanding of how that mechanism works, but they can monitor blood pressure just like they do cardiac monitoring at home, and they can transfer those same records over apps as well. So those are your tests, and you can make sure that those are concentrated for hypertensive diagnosis. There are about 7 lifestyle changes for managing hypertension and health that's extremely important for you to understand why we're doing that. Weight loss and blood pressure reduction. Um, the number here, and this is the carrot approach, you can it's possible to lose 5 to 20 reduction points in blood pressure for every 22 pounds lost. This can vary, but for every millimeter of mercury of blood pressure is decreased for every pound lost. That's significant. DASH diet stands for Dietary Approaches to Stop Hypertension Diet. This evidence shows that there's eating plenty of fruits and vegetables, grains, nuts, dry beans, fiber, lean meat, fish, poultry, low-fat dairy, and reducing total fat consumption can potentially reduce the systolic blood pressure in hypertension patients by 11 millimeters of mercury. And this has been tested for almost 20 years now. Recommended daily servings of fruits, they look at about 4 to 5, vegetables 4 to 5, grains 7 to 8, low fat dairy 2 to 3, lean meat, poultry or fish less than 2, nuts, seeds, beans about 4 to 5 servings every week. So that changes from the daily to the weekly here. They want the reducing of the sodium and the salt by about 1,000 milligrams a day. This can potentially reduce systolic blood pressure by 5 to 6 points um, in patients who are diagnosed with hypertension. Teaching patients how to read food labels, and I put that on the slide there because it shows you the newest food labels that are out there on the market today. This shows you how to read the food labels, how to use canned foods sparingly, opting for fresh or frozen or low sodium as much as possible. And remember, health literacy plays a big role in how patients can read. They can use the the reading and writing and numeracy to understand these labels. And so looking at the sodium in this particular label is very important. Things like soups and um, have a lot, depending on the type of soup it is, can have a lot of sodium in it. Got to be careful with that. You could use up your daily allowance of sodium very quickly. Canned goods should be used pretty sparingly. There are plenty of things in the freezer aisle that are very easy to use, but depending on the patients, this is where patients' lifestyle. Do they not have a freezer space? They may have a very small freezer. They may live in a very small area, may only have a dorm size refrigerator or freezer. They may not be able to have that kind of thing. So who knows? These are the things that you have to ask, and that's why dietitians and some of your other healthcare professionals can ask these patients, even nursing can ask these patients, because they may not have the ability to prepare their foods, and so that's why they use canned goods a lot. Increase of potassium, you want to aim for 35 to 100 to 5,000 milligrams daily of potassium, preferably from food that's not supplements. Increasingly, people turn to supplements to make it easy because they can't get all this different food. Uh, it's just so much better to take the real food and eat it, not to have the supplements. Examples of the food products are listed on that slide. They have things like sweet potatoes, and tuna, low-fat yogurt, bananas, tomatoes, um, spinach. There's a good variety of foods there. Understandably, patients with diabetes or other conditions have to watch their food choices for the hidden sugars that are there. But the sugars in fruits and things like that are I'm not so much worried about as I am more so the added sugars that go along with um, the dietary guidelines for diabetics. But the preferences will always go more towards your natural food products over supplements if possible. You can potentially reduce the systolic BP in patients with high blood pressure by 4 to 5 millimeters of mercury with getting your potassium on track. Exercising regularly, you can reduce it by 4 to 8 millimeters. Recommendations are to attempt to do 30 minutes of moderate aerobic exercise most days of the week. That could be through walking. It could be chair yoga. It could be isometric exercising, resistance training. Um, if you have a computer at home, if you're on Medicare, there's a free service called Silver Sneakers. You can have free membership to gyms all over the place. You don't even have to have uh, pay a dime for it. Um, you could swim, that kind of thing. So there's all kinds of programs. It depends on what you can do. You may need to, if you've never exercised before, I would have patients talk to their provider and see if there's physical therapy. If they live in an assisted living or a rehab facility, physical therapy is in-house and they can help them get established on a routine, something they can do at home or if they need help to establish a routine. Most of the time, if people are left to their own to do it without that assistance or someone to help guide them, do it with them, they'll not do it. So it's important to find out what they will commit to. Limiting alcohol, we talked about this before, but if you limit alcohol to 1 drink a day for females, and 2 drinks a day for males, you can lower your blood pressure by 4 millimeters mercury. Smoking, if you can quit it now, wherever you are in life, that means vaping, chewing, whatever it is, tobacco wise. Quitting is not easy. Get into a smoking cessation program. You can lower your BP 2 to 8 millimeters. There's another diet option out there that's very, very good. It's the Mediterranean diet and brings good health. It's unlike the typical American diet, which is really loaded with saturated fat. The Mediterranean diet is high in fiber and low in saturated fat. And while this diet is not necessarily low in total fat, the types of fat that is emphasized are the omega-3 or the healthy fats or unsaturated fats, and those that are found in olive oil, which do not raise cholesterol levels. So that's an important factor. Just like there are multiple countries that live on the Mediterranean Sea, there are variations on the Mediterranean diet. But there are lots of common characteristics woven in the diet that the American Heart Association has highlighted, and they include limiting the amounts of red meat, maybe once per month, weekly amounts of eggs, poultry, fish, or sweets, daily amounts of cheese, yogurt, olive oil for everything, using fruits, vegetable, pasta, beans, nuts, and whole grains. And then your beverage, they have wine just about for every meal, but they have water, 6 to 8 glasses of water every day. And then they have physical activity woven into their daily life every day, unless they are completely debilitated. But for the most part, they're doing some form of activity every day. There's been a lot of research on the potential health benefits of following this diet. And according to studies, this diet may offer these benefits, reducing the rate of death in people who've had a heart attack, reducing the rate of heart attack and stroke in people who have heart disease, uh, reducing weight, lowering the rate of cancer, lowering the HbA1c levels or measurement of how well the body uses blood sugar in people with diabetes, reducing pain in rheumatoid arthritis patients, lowering the risk of developing type 2 diabetes, and lowering the risk of metabolic syndrome, which has become very prevalent in the American diet in the society. So that pyramid shows you the high ranking. So this is some we just talk about things in different tones here, but the physical activity is something at the bottom of this. Every day they have physical activity. So when you think about the way people live in the Mediterranean, they walk everywhere. This may be something that we cannot do in this country. So depending on where you live, your neighborhood, um, the terrain, the safety of your neighborhood, what you can do, what you can't do, the weather. Is it warm? Is it cold? What is it like? You may be able to have activity every day. So it's just one of those things that you have to adapt to where you live and do what you can. But it's a very great, as far as the food that is chosen here, very, very strong advocate for health. Stress reduction tools for hypertension. And this is a slide that shows you the different tools that are available to help you with coping mechanism and introducing some stress reduction for reducing hypertension. Fight or flight responses are stimulated in situations where there's a perceived loss of control or an actual loss of control. And in every hospitalized patient, these are vulnerable situations. You're seeing patients at their most vulnerable, and they are the ones that are where we control the narrative of just about everything. Um, what they eat, I mean, they get choices on their menu, but we deliver it when it comes. Um, it's their perception, and the key word there is perception of a loss of control. Patients now have a lot more control than they ever have had in the past, but they still have uh, a fear of being out of control of their situation because they're not at home and they're not in control of their faculties sometimes. Maybe in pain and maybe requiring services rendered to take care of their um, bowel and bladder functions, things that are very shameful and embarrassing. So you'll see that their stress level is really, really high while they're in the hospital. So they could, in the daily lives, they could have stress, like major life changes. Maybe there's a death, maybe there's a birth, maybe there's work situations or lack of support from a supervisor or a coworker. Difficult personal relationships with family or spouse or friends could be addition to other commitments that are necessary for a livelihood of things. They could have uh, support of church or clergy or hobbies or things that help mitigate stressful situations. But to counteract those sometimes overwhelming situations, you have to learn where your tools are. And so this slide shows you some different things to use. When you see patients, they don't know you, the first thing they want to do is to figure who you are. And your job as a nurse, the first thing that I was taught to do is to allay fears. So when you introduce yourself, you start to examine them for assessments, asking them to take deep breaths when you're standing by them for procedures, always holding their hand, helping warm them up, getting them giving eye contact and connecting, making those connections, allowing them to breathe deeply, gets oxygen into the body. You can feel them either tense up or relax. It's up to you to lead the way to that more relaxed state. And if you're present with them during that period, you are allowing them to get that vasodilatation process, get that relaxation process going, help with that relaxation, and help them lower that blood pressure, help them even start to try to watch them lower their heart rate sometimes and just relax. And you can do that sometimes with just deep breathing and just getting them while you're doing your assessment to take those deep breaths while you're listening to their chest. They start that routine. And you can do that very easily without them even knowing that you're using some relaxation techniques. So some of the things that they ask, they tell you to do is to get creative, get some good sleep, use your relaxation techniques like I talked about. Confront that stress. Don't push it down. Don't try to push it to the side or you know um, wait around to solve it. Go ahead and confront it and get it over with. Strengthen your social support. Have extra people around you. Get out, volunteer, be a member of an organization. Um, just expand your folks, your tribe, so to speak. Use laughter. Finds the funny in things. You don't have to laugh at people, you can laugh with people. If you don't have good time management skills, learn how to be a better time manager. Um, and if you still feel after you've tried some of these things that you're still depressed, have anxiety, or you have lack coping mechanisms, or you're going through some very harsh um, periods where it seems like more than one stressor, major stressor, um, or you're hitting the top 10 stressors in life all at one time, it may be time to reach out to your provider and you may have to seek some behavioral health assistance. It's not uncommon. So, helping patients build this toolbox can help build a treatment strategy that will help with their blood pressure issues. So we're finally getting into the medication classes. Finally, our medication classes are for hypertension management, and those that have been shown to prevent cardiovascular disease are recommended first line for most patients. Our guidelines for stage one, we're looking at lowering that blood pressure down. Um, so we want to look at four common classes. Those are thiazide diuretics, calcium channel blockers, ACE inhibitors, and ARBs, which are your angiotensin receptor blockers. Starting by taking the lowest possible dose of one drug and gradually increasing that dose until needed, until the blood pressure falls to a normal level. If that drug causes troublesome side effects, the doctor is going to reduce that dosage and replace it with a different medication. Several medications may need to be tried before a drug that is found that works best for the patient. So it's recommended specific for African American patients with hypertension, but without heart failure or kidney disease, that they use thiazides or a calcium channel blocker, not an ARB or an ACE1, ACI. Simple prescription schedules are optimal to promote adherence to taking antihypertensive, which would be something like taking one time a day, taking all, if they could combine medications, it will work better. The dosage needs to be increased or another medication added. So those simple things that will help people to stay on track with their regime is optimal. And you look here on the first line drugs, it's just trying to make sure that purpose is to lower the blood pressure, reduce the risk of cardiovascular disease, and reduce the risk of death. That is the major goals of all these meds for these patients that have hypertension. This slide is really just wants to remind you that remember what is chosen is based on the individual's underlying conditions and evaluated responses to these medications, especially if this is the first time they've been diagnosed with hypertension. So this is your thiazide diuretics, your furosemide, your loop diuretics, and then also your angiotensin aldosterone receptor medications. So this is just an example illustration of your kidney uh, glomerular filtration system. For people with stage 2 hypertension, the guidelines recommend starting with two first line drugs of different classes, and the best drug or combination of drugs will depend in part on the patient's risk of heart disease or any other medical conditions they may have. So same thing happens. You're going to choose some different drugs to go along with these. And we'll talk about that in just a sec. So to simplify, if you look at the current guidelines for hypertension, there are about 6 drugs you truly need to know at this point. Keeping with the goal of keeping the blood pressure less than 130/80, or in this guideline, there's age-related increase, an increase with CKD and DM, or for 140/90, you would add 2 additional types of medications. So the first would be an ACE inhibitor, which could be lisinopril, captopril, those type of drugs. Your angiotensin receptor blocker, a losartan or valsartan. You're going to choose one of those. Thiazide diuretics, your furosemide, torsemide, hydrochlorothiazide. A calcium channel blocker will be elopidine, verapamil, nifedipine, diltiazem. If the blood pressure goals are not met, then the choice would be made from these 2 additional classifications, which would be a beta blocker, which would be your metoprolol, covalol, your aldosterone, which would be antagonist, which would be your spironolactone and apelrinone. And remember, your spironolactone is your one that is potassium sparing. So look this up in your text. There's a page number that's highlighted. Make sure you look that up. It's a huge list of drug medications, but basically you're going to concentrate on your drug cards from your previous pharmacology course too, that has those 6 medications, and just look those up and be aware of when you use that. And in your notes, I noticed a calcium channel blocker. You should have a number 4 by that, but you understand what I'm saying. There's those 4. Your slide is correct, but notes have that missing. So these guidelines that we talk about, they've changed about every 10 years or so. And so the slide has current 2017 information that may be helpful when reviewing the different medication options. Just be aware that some of the preferences that come out in 2025 may be a little bit different, and there may be new drugs that have come on the market since this guideline has changed. So it may take time for cardiovascular teams to adopt and change protocols, order sets, and such. So give this slide a bit of brief overview. This is what is being used currently. So just pay attention to that, and also pay attention to the guidelines for the pregnancy and the clonidine. Those are probably going to be used more so for either very harsh situations, emergency situations, not so much on a regular basis. So just pay attention to those things. And some drugs are preferred now, and you just have to weigh on the patient's individual needs. So I wanted to reiterate about the new risk-based thresholds in 2025, and this is the algorithm type treatment for adults. This is the use of risk-based thresholds. Uh, it's important that you know what this estimate will look like. It can estimate 10-year and 30-year risk for total cardiovascular disease in people from 30 to 79 years without known cardiovascular risk. This prevent tool includes kidney and metabolic health factors in the equations for a more comprehensive and precise estimation of risk compared with previous tools. This tool also starts younger to start prevention strategies because the data collected over the decades has shown that those middle-aged year adults, when managing hypertension and cardiovascular risk, can prevent the development of stroke, dementia, and Alzheimer's, as well as other health issues related to the cardiovascular system. So it's extremely important that you're aware of this change and review this a little bit. It's not that it's going to be on a test or anything, but this is so helpful for you to know. I think this is going to benefit. We've had so much dark and gloomy information come out for prognostication of the health between now and 2050, which is not going to be too far away. So this is going to be your nursing future and what you're going to be seeing. So I want you to be aware of it, and just see what those parameters look like so you can just be kind of ahead of the game. So my favorite thing now is doing performing a nursing assessment for the patient with hypertension. So thorough health and history physical is necessary. This has all been done already by primary care providers. It could be an MD, advanced practice nurse, um, hospitalist, or PA. Preceptors and students perform assessments all the time, and most of the time we do focus assessments because unless the patient permits a complete assessment, it takes so long to do a complete and thorough assessment, you get interrupted all the time. So a thorough H&P in a hospital setting is very you have to plan it very carefully and make sure you have uninterrupted time, and a patient that accepts the challenge to have a hour-long assessment done. So people are not able to withstand a physical like what we would be doing in an office setting. So you're doing assessment after the initial H&P is done, and these are the steps. You've already received a report on this patient's diagnosis of hypertension. What do you see when you're inspecting the patient? What do you feel? What are you hearing when you're going to auscultate? You have to introduce yourself. You're going to be needing to start care on that new patient. So you're going to assess um, patient's orientation, the cognition, the recall, the memory, the ability to follow commands. This could reveal signs of dementia, that white matter disease that we were talking about, electrolyte imbalances, or hypoxia. It could include palpation of all your peripheral pulses. Are they absent, weak, delayed? What about your femoral pulses? Are they delayed? This could mean a coarctation of the aorta, or it could be severe peripheral vascular disease. You'll be looking at the neck, seeing if they're uh, examined for bruits, distended jugular veins. You're going to be listening with a stethoscope over your both neck arteries, carotid arteries. You're looking for that distended jugular venous distension there, or enlarged thyroid gland in the neck. You're going to be feeling it, see if there's any nodules. If it's making their voice hoarse, the upper abdomen should be auscultated gently for the presence of a renal bruit that could mean renal artery stenosis. Um, you shouldn't be able to feel a liver, but if you do, you want to make sure that you're going to be um, feeling that up under that rib cage. You could also, on a cardiac exam, this is really important. Um, it should be carefully undertaken. The room should be quiet, so turn down your television. Make sure that the phone is off or whatever. You want to evaluate for enlarged left ventricle, and so the way you do that is you're going to be looking for that PMI. Where is it? Is it displaced? Does it mean that that is an enlarged heart? You would expect that that PMI would be shifted somewhere over. You know where your PMI is normally. So if that heart is enlarged any, it's going to be different. You may hear a S4. So signs of heart failure could be there present. So you might see through your lung sounds, rouse or diminished breath sounds. You could hear congestion. You could have them they're coughing up frothy sputum. It could be very congested. It could be short of breath. Um, pulse oximetry, vital signs all could convey what you're hearing. And so when you compare what you have seen on your assessment and you look at your vital signs, there could be hypertension. It could be over 130 over 80. Their pulse oximetry could be below 95. You could have the tachycardia. Is their heart rate regular or irregular on auscultation? Could you actually think do you actually think that they're having some kind of palpitations? Are they having any chest pain? What is the patient complaining about? That kind of thing. So these are the things that you're looking at on your assessment, and then you're going to be looking at their skin color. Are they warm? Are they cold? Are they having any slow blanching of their nail beds that would show signs that they're having some slowed peripheral circulation issues, maybe some peripheral vascular disease. Are they having any difficulty with memory? Do they know that they certain things, but they don't remember other things? Are they able to sit up for you? What is their strength? Is it the same on either side? Are they having any signs of a stroke? So these are all the things that are talking about circulation and signs of hypertension. While you're doing your assessment, are they having any changes um, in responses to you, which could mean that they could be having a TIA, or do you need to call someone a rapid response? So some of the things that people are having undiagnosed or just recent diagnosis of hypertension, or they're having a hypertensive crisis while you're doing this assessment, you would stop and you would address the situation immediately. So these are a lot of times somebody else is doing vital signs for you. So these are the things that you need to compare and contrast. If somebody took vital signs at 8 o'clock and you're doing a 9 o'clock assessment, you want to make sure that you're aware of that, and then aware of any medications they took before your assessment. They may have been given some pain medication or something. So you want to make sure that you have assessed all of those things um, and weigh into your total package for your assessment to make sure that these responses weigh into your final decision about what you're seeing for your preliminary nursing diagnosis. This resource that I'm giving here is helpful for information to guide you in knowing how meds can benefit or adversely react with other meds. It provides some information on how to proceed with caution or when to seek alternatives altogether. So this is something that you may not find as good advice to provide for your patients. So this comes from Harvard. So I think this is a good little tool to have in your pocket when you're compiling some of your information for your patients. But this is a good, if some people ask you questions, you have information to provide for them. So here are my references for this particular presentation. There's lots of information out there, especially the new resources that have come out with this new guideline on 2025 from the American Heart Association and other professional organizations, like the American College of Cardiologists. It's extremely important. It's a very big book. You should have that guideline as a reference, and you can look that up. But I really did enjoy researching some of the stuff for you. Please, if you have any questions, just let me know. And have a good week studying, and I look forward to talking with you. And pay attention to the instructions on and announcements this week. So take care.